Welcome everyone to today's webinar. This is Diana Arias with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Suicide Prevention Among School-Aged Children. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the bottom of your screen and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during today's webinar, and we will address them towards the end of the presentation. We are very excited to have with us Dr. Ariel Sheftall, a principal investigator at the Center for Suicide Prevention and Research, housed within the Research Institute at Nationwide Children's Hospital. She's also an assistant professor at The Ohio State University College of Medicine. Dr. Sheftall has co-authored numerous articles focusing on suicide and suicide-related issues affecting children and adolescents, many of which are easily accessible electronically. Once again, thank you for joining us, and I will now pass it along to Dr. Sheftall to get us started.
Well, thank you all for being with us today. My name is Ariel, as everybody knows. First and foremost, I just wanted to do some disclaimers. I do receive funding from the National Institute of Mental Health, and I have no financial relationships or conflicts of interest to disclose. So the objectives of this webinar are four, to be complete. I'm going to give you guys a brief overview of the prevalence of suicide and suicidal behavior in school-aged children. Going to do a very brief overview of the research that's been conducted and tell you a little bit about the findings for this population. Then highlight some of the specific therapeutic models and interventions, programs that have been used in this age range, and then finally discuss some of the implications for mental health practice. Before we move forward, I wanted to do a quick poll question. So I wanted to get a better understanding of who we have with us today that's watching the webinar. So I wanted to know what setting you all are working in with children. If you can, please respond A, for outpatient centers, B, for inpatient centers, C, for schools, D, for residential, and then E, for other. And if you do respond E for other, if you can just tell us what that other facility or center is, that would be very helpful. I'll just give you guys a brief moment to respond to that. And while you are responding, I just wanted to give you first another disclaimer and then also give you a brief overview of my research background. So I have to be completely honest, I am not a clinician. I do not do therapy. That is not one of my expertise. I have been trained in clinical interviewing and have been in the suicide field for over 13 years now, working with families, with children who have had experiences with suicidal ideation and behavior, as well as adolescents. So just wanted to let you all know that that is not my area of expertise. Therapy is not something that I have done myself. But in terms of my primary responsibility, I am a researcher at Nationwide Children's Hospital, and I conduct research that is primarily focused on discovering early vulnerabilities in youth that can be associated with suicidal behavior later on in life. So right now I have a couple of studies where I am trying to gather some information about young children, 6 to 11 years old, that have experienced suicidal ideation, as well as children that haven't had any suicidal thoughts or behaviors but are at higher risk because they have a parental history of suicidal behavior. So that will not be the focus of my talk today, but if you do have questions about that, we can talk about that a little bit later on during the question and answer session. All right, so it looks like about 34 of the 132 that responded are in an outpatient setting, and then there's 35 of you all that are in other areas. So we've got a good grasp of folks that are on the line. So let's go ahead and get everyone on the same playing field, so to speak, when it comes to definitions. So throughout the presentation, I'm going to be using these words pretty frequently, so I just wanted to make sure that we are all on the same page. So suicide, when I use that word, I am talking about the death of a person who actually died by a self-inflicted act with explicit or inferred intent. When referring to suicide attempt, that is a non-fatal self-injurious behavior that does have the stated or inferred intent to die. Suicidation is thoughts about ending one's life. And then finally, suicidal behaviors is the umbrella term that we use in the field that corresponds to all of the thoughts that could be associated with suicide, the behaviors that could be associated with suicide, such as suicide attempts and suicide death. So as many of you have seen in the news, unfortunately, there has been a lot of headlines corresponding to suicides in young children. Overall, when you look at youth, suicide in young children is pretty rare. However, in the last couple of years, it seems that everywhere you look in the news, there's a headline concerning a death of a child. And unfortunately, we don't know a lot about suicide and suicidation or behavior in this age group because the majority of the research that's been conducted has been in adolescents and adults. But we do know one thing is that suicidal behaviors are occurring at this age, and unfortunately, it seems that every time we look in the news, there's another headline. And the one thing that I always state is that one life lost is one too many. So research in this area is definitely needed. So now I'm going to give you all a brief overview of the prevalence of suicide and suicidal behavior in school youth. And this focus of the presentation is going to be on children 5 to 11 years old. I do have a couple of slides that do address children up to the age of 14 years old, but majority of the slides are going to be focused on that younger age group, 5 to 11. If you do have questions about teens or teenage suicide, please feel free to write those in as I'm going through the presentation, and hopefully during the question and answer session we can address those. So the problem of youth suicide, when examining suicide overall for all age groups, it is the 10th leading cause of death in our nation. And then when you look at youth, 5 to 11 years old, it's the 9th leading cause of death. And this data comes from the Centers for Disease Control and Prevention, CDC. And as you can see, unintentional injury still is the leading cause of death for children in this age group. It is pretty rare for children to die by suicide, but in 2017, 59 lives were lost in this age range. 46 of those were males and 13 were females. And the highest rate of suicide for this age group was seen in Black youth. And the first time suicide became a leading cause of death for this age group was in 2014. And at that time, there was 49 suicide deaths that had occurred for that year. In 2016, it actually became the 9th leading cause of death for this age group and accounted for 53 lives lost. When examining the state of New York specifically, there is data available, and this data, I apologize, is from 2016. So I wasn't able to find more recent data, so I apologize for that. But what they found is that for all age groups, there was a 2.8% increase found in the suicide rate from 2015 to 2016. And in 2016, for children 5 to 14 years old in the state of New York, there were 22 suicide deaths. the majority of the youth who died by suicide were white, male, non-Hispanic, and died by hanging suffocation. And as you can see on this chart here, it breaks the suicide deaths down by age group, sex, and race. And then this next slide also discusses the method used as well as veteran and marital status. And again, these slides look at suicide in all age groups. In 2016, there was a report that was published by the New York State Office of Mental Health, and it looked at suicide data throughout the entire state, and also actually spelled out some recommendations and solutions for prevention. And it can be found at this website here, and I definitely would recommend it if this is an area of interest for you all, which I'm assuming it is since you're on the call and the webinar. And it goes through a great deal of information about the statistics. It breaks it down on what prevention strategies would be best for certain areas and how they planned on implementing those interventions as well. And then one of the slides that I've included breaks down some of the data that they presented that looks at the state as a whole and tried to figure out where the suicide rates were the highest in terms of the counties. So again, this data, unfortunately, is a little bit more outdated. It was from 2014. So for 2014, the state of New York had a suicide rate of 8.6 per 100,000 persons. And that number was an increase from 2004. So they looked at the past decade and tried to figure out what was the percent increase that had occurred. And what they found is that an increase of 32% had occurred from 2004 to 2014. So in 2014, there were 1,700 suicide deaths for all age groups for the state of New York. And there were only 4 states that had a higher suicide rate than New York. When examining the state geographically, what they found is that the northern counties had the highest rate of suicide at 13.8 per 100,000, and that looked at data from 2011 to 2013. And they found that New York City had the lowest rate of suicide, which was at 5.8 per 100,000. So that's some data on New York itself. When you look at suicide rates in 5 to 11-year-olds and you try to break it down by sex, what you find is that there is a sex disparity. And this is something that we see at all age groups, unfortunately. So males in this age group have a suicide rate that's about 3 times higher than females. And in 2017, male suicides accounted for 76% of all suicides in this specific age group, 5 to 11-year-olds. However, in a recent study that was published by the CDC and another study that was published by our research group, we found that females, 10 to 24-year-olds, are having a significant increase in the rate of suicide, and that this gap between males and females might potentially be closing. So unfortunately, the suicide rate is increasing in all age groups, but also the suicide rate in females, young females specifically, is increasing as well. When examining suicide in youth by age and sex, as you can see here, it is pretty rare in children 5 to 11 years old. But for youth 12 to 19 years old, that number changes drastically. So in 2017, there were over 2,900 deaths that occurred for children 12 to 19 years old. And this gave us a rate of 8.8 per 100,000. When examining method of suicide, there's also some sex differences that are present. However, for this age group, the main cause or main method or mechanism used is hanging suffocation. So the majority of males and females who died by suicide during this decade of examination died by hanging suffocation. Males were more likely to die by firearm compared to females, and females were also more likely to die by other methods used. So unfortunately, hanging suffocation is the leading cause of method in youth in the U.S., and it is not only a phenomenon seen here. A recent study was conducted in Canada that found that suicide by hanging suffocation was unfortunately the most common method used in youth 10 to 19 years old as well. When you examine suicide by race, for this specific age group, 5 to 11-year-olds again, we found that Black youth have a higher rate of suicide compared to the other racial categories. So this graph is per 1 million youth because, again, the rate of suicide in this age group is so rare. So 2.94, if you round it up, 3 individuals of Black race die by suicide per 1 million youth in the U.S. So now that we've talked about suicide deaths, I wanted to talk very briefly about self-harm behaviors. So the Center for Disease Control and Prevention also gathers information from emergency departments around the U.S., and they look at self-harm behaviors, specifically suicide attempts or any other behaviors that are self-harming, and they break it down by those that get discharged versus those that are hospitalized, basically admitted to the hospital because of these self-harm behaviors. And when I looked at the data for 5 to 9-year-olds, what you can see is that this dotted line here is the trend line. So that, unfortunately, from 2001 to 2017 has increased. And in 2017, there were 126 injuries that occurred in 5 to 9-year-olds that required hospitalization. In 10 to 14-year-olds, you can see that the increase is much steeper. And for 2017, there were over 8,400 injuries that occurred from self-harm behavior for 10 to 14-year-olds that required hospitalization. So now that I've given you a brief overview of the prevalence of suicide and suicidal behavior in youth, I wanted to talk about the research findings in school-aged youth. So I'm going to be discussing some of the studies that we've conducted as a group, just to give you some insight of what we've found in elementary and middle school-aged youth. So the first study that we conducted examined elementary school-age children specifically, and we classified that as 5 to 11 years old. And we looked at a sample of youth that had died by suicide, so 657 youth, which is approximately 33 deaths per year. And we looked at data from 1993 to 2012. And in 2012, suicide was deemed the 11th leading cause of death for this age group. And now, as I stated, CDC has unfortunately put suicide at as the 9th leading cause of death in this age group. The majority of the children that we examined were male, Caucasian, non-Hispanic, and majority were in the 10 to 11-year-old range. And when examining method, majority unfortunately had died by hanging suffocation. When we looked at the trend over time, so we tried to figure out, okay, has there been an increase in the suicides in this age group? We didn't find any significant decrease, any significant increase when you looked at the group overall. However, when you examined the group by race, we did find that there was a significant decrease present in white youth and a significant increase present in Black youth. And that's pretty much why we didn't find a difference in the rate over time when examining the group as a whole. The racial difference led us to investigate some of the sex differences that may be present, and what we found is that in Black males, there was a significant increase compared to white males. But for Black and white females, there were no differences found. So as can be imagined, this manuscript sparked a number of questions, and one of them was why? Why are Black males dying at a higher rate compared to their white counterparts in this specific age group? So we conducted another paper or another study where we looked at the National Violent Death Reporting Surveillance System, or NVDRS, data. And this data set is a very, very rich state-based surveillance system that collects data on all violent deaths within that state. This data set has multiple reporters that are giving information, so medical examiners, coroners, law enforcement are all giving information to this system, and then it's aggregated to be able to examine some of the factors that may have been related to that individual's death. And currently it's active in 32 states, and by the end of 2019, the CDC, who controls the NVDRS, is hoping to have it active in all 50 states. So for this specific analysis, we had the restricted use data set available, which was on 17 states at this point in time. And what we wanted to do is figure out what were the precipitating circumstances that could have been present prior to this child's death. So we looked at basically a number of things: mental health history, treatment, relationship problems, job crises, substance use issues. And we compared groups by age, so 5 to 11-year-olds compared to 12 to 14-year-olds, and then we also compared by race, Black youth versus non-Black youth. And what we found is that in total, there was 87 children who died by suicide that were 5 to 11 years old, and 606 early adolescents who died by suicide. And this bar graph shows you the differences between the groups. So 5 to 11-year-olds were more likely to die by suicide if they were male, Black. They were more likely to die by hanging, suffocation, and also to die in their own home. Here are some more precipitating circumstances that we found. Early adolescents were more likely to have boyfriend or girlfriend problems prior to their death. They were more likely to have a suicide note present. And if they were diagnosed with a mental health concern, they were more likely to be diagnosed with depression or dysthymia. Whereas for children, they were more likely to have other relationship problems with either a peer or a family member. They were also, if diagnosed with a mental health concern, more likely to be diagnosed with ADD or ADHD. And one of the things that I wanted to mention that's not present on this slide was the rate of disclosure. So when you looked at the rate of disclosure, how many times a child told someone that they were thinking about suicide or that they were actually going to take their own lives was not significant between the groups. 30% of the children who died by suicide in our sample had disclosed to someone, whereas 29% of the early adolescents had disclosed to someone that they were thinking about taking their own life or had suicidal thoughts. So this just speaks to the fact that any disclosure by any child, no matter how many times, should be definitely taken seriously every single time. And the last study I just wanted to talk very briefly about, which we just recently published last year, examined children 5 to 17 years old. And what we're trying to do is figure out, okay, we know that kids 5 to 11 years old are more likely to die by suicide if they are of Black race. But when does this shift, so to speak? Because we know that at older age, Black youth are less likely to die by suicide. So we looked at all of the rates over time, over the age span from 5 to 17 years of age, from 2001 to 2015. And what we found is that Black children 5 to 12 years old were 2 times more likely to die by suicide compared to white children. However, Black youth 13 to 17 years old had a suicide rate that was approximately 50% lower than their white counterparts. And then when you stratified the analyses by sex, so basically when you looked at males and females, you found similar results. So that is the majority of the research and the stats and all that I will be talking about for prevalence, so to speak. So I wanted to stop here and give you guys a little bit of a stats break, so to speak, and give you time to respond to the second polling question before we get into talking about therapeutic interventions and programming. I just wanted to ask you guys, what were your concerns about talking to young children that express suicidal thoughts and actions? And just wanted to get some insight from you all. If you can respond, A, B, C, D, and through F. And if you do respond E, if you don't mind just listing out in the chat what those actual concerns are, I'd greatly appreciate that. I'll just give you guys a couple of seconds to do that. And I can just tell you my own experiences. I think for me, the one thing that was a major concern for myself was that I didn't know how talking about suicidal thoughts and behaviors would affect that child specifically. I've done research on examining talking about suicide in teens and how that relates to not encouraging suicidal behavior and thoughts in teens, but talking to younger children was always a concern for me. And I think now, with the experiences that I've had with my own research, I've realized that children understand what we are speaking of when talking about suicide. And I would rather be able to address concerns in a safe place versus having a child express a concern and not being able to have someone there that may be able to help them get the help that they need. So that is probably some of my experiences. And yes, challenges with working with children's family members is the majority of what you all responded to, and that does play a huge role. The quality of services and therapy available is also a huge role and why, or you would be concerned as well with working with young children. And I'm hoping we'll see what the future holds, that telemedicine will help with that, but it still is a major concern, obviously, when thinking about suicide and suicidal behavior in young youth, and young children, I should say. All right, so let's move forward and start talking about some of these therapeutic models and interventions that we were able to find some information on. Before doing so, I just wanted to have one slide in here about what can we do. So as I told you, I'm not a clinician, but there are things that I can do to help if I do see someone at risk. So the first thing to do is to pretty much know what the warning signs are. So wanting to be alone all the time, having less interest in usual activities. What does that mean? Well, if a child is very heavily involved in soccer and then all of a sudden they stop being involved in soccer because they no longer want to do it, that's a concern. That's a major concern. Giving away important belongings has actually been seen as a warning sign in young children. So a child may give away a prized possession like a favorite stuffed animal to another person or to a sibling because they feel as if they aren't going to need that anymore. So because they are going to be taking their own lives. So that is definitely a red flag. Risky and reckless behaviors. So if you see a child that is all of a sudden becoming more risk-taking. So if, say, for instance, a kid starts jumping off of things and it's not something that they usually do, or if they're, doing something that just doesn't seem their norm, so to speak, that should be something that should be considered a warning sign. Self-injury obviously has been associated with suicidal behaviors, and then also increased substance use in older youth and adults as well has been associated with suicide and suicidal behaviors. So if any of these warning signs do occur, what do you do? Well, seek some help. So if a child is threatening to attempt suicide, if they're seeking means to kill themselves, definitely big red flags that taking that child to the emergency room is necessary. Talking or writing about wanting to die in school or via social media, definitely a red flag as well. So please, please, please do all you can to get that child to a safe place. So those are things that I can do as well as others, just knowing what the warning signs are and then also knowing what to do when it's necessary to get that child help. And the emergency department, thank goodness, is always open, and hopefully there's one available close by. So some of the therapeutic approaches that were found, and this is not an exhaustive list. There are some, I'm sure, that we did not find. My staff member and I did our best to search as we could. But the ones that we thought would be helpful was first this consultation service that was presented that worked with very young children. And the consultation services are set up to focus on increasing resiliency as well as helping youth with their social emotional development and building positive relationships between the caregiver and the child. So the first one that we found was the Early Childhood Mental Health Continuum of Care. And this service addresses mental health needs for very young children, 0 to 5 years old, and it follows a continuum of increasing support. So it ranges from promotion to prevention, early intervention, and then treatment. And it also offers some support and education and consultation for caregivers as well, so that they are able to help their child develop socially and emotionally to the best of their ability. The second one that we found was the Center for Early Childhood Mental Health Consultation, which primarily works on externalizing behaviors, to be quite honest. It was, again, for 0 to 5-year-olds, and it was very much interested in establishing consistent boundaries, helping children understand their emotions, giving their feelings names, also helping them manage the frustrations or the outbursts that they may have. Again, building these positive relationships between the caregiver and the children. And then finally, building a capacity to use effective strategies at home. So, during consultation, they're taught these skills, but how can they use those at home to address behavior problems, emotion dysregulation outbursts, and then also in school if they're in kindergarten as well. So very much establishing some skills that can be used to help with emotion regulation and strengthen support for caregivers is what the consultation services seem to be focused on. There is one therapeutic approach that I was able to find that has addressed suicidality in adults and teens specifically. So this is the Collaborative Assessment and Management of Suicidality Therapeutic Approach, or CAMS. And it's a framework where clinicians pursue suicide-specific treatment in a supportive, collaborative, problem-solving, non-judgmental manner. It uses quantitative and qualitative approaches for assessment. So that means clinicians rely not only on numbers, but also spoken word from their patients to understand how their patients are doing. And they use these types of assessments to examine psychological pain, stress, agitation, hopelessness, and self-hate. And throughout the session, the patient and the clinician identify reasons for living and dying and the triggers that are associated with the patient's suicidal thoughts. Together, they develop a treatment plan to identify, target, and treat the triggers of suicidal ideation and behaviors. And CAMS has been found to be useful across multiple therapeutic frameworks, and it's actually based off of the suicide status form. I was going to go through that form very briefly with you all so you can get a clear understanding of what CAMS is using. So this is the first page of the suicide status form, or SSF. And basically, CAMS is all about gaining a better understanding of how the patient is feeling at this point in time when they are seeing them. And this is done in a collaboration with the therapist. So the first thing the therapist does is actually ask the patient if they can sit with them side by side. And then they show them this form, and they start to complete this form together on a clipboard. And it provides an important framework for both the patient and the therapist in understanding the nature of the patient's suicidality. So this first page takes about 10 to 15 minutes to complete, and it's asking the patient to rate on a scale of 1 to 5 how much they are experiencing these specific things, so psychological pain, stress, agitation, etc. And then on the second page, which is not listed here, the clinician fills out what types of risks are present for this specific client. So if the patient has a suicide plan, if the patient has a history of ideation, of attempt, are they very impulsive? So lists out yes and no's for these specific risk factors that have been associated with suicidal behavior. And then on the third page of this form, the clinician and the patient come back together and determine what type of treatment plan they want to use moving forward and what goals and objectives they're going to try to reach together as a team. So for example, say for instance, the first problem will be to address self-harm behavior. And the goal is to obviously ultimately avoid self-harm behavior, but also to provide details concerning safety. So that can be done on an outpatient level of care. So when this patient is not present, how can they take care of themselves and make sure that self-harm behavior isn't going to happen? So the intervention could be providing the crisis hotline, could be avoiding places where self-harm behavior is likely to occur, doing homework assignments that the clinician asks the patient to complete. And then you set a time frame for this intervention. So 2 times a week for 4 weeks, we're going to address the specific problem. And altogether, the collaboration between the patient and the therapist provides some buy-in from the patient and gives them a sense of control over their therapeutic intervention. And at the moment, we are actually getting ready to pilot the CAMS model in children here at Nationwide Children's Hospital, 5 to 11 years old, with the hope that it actually can work for this age group as well. It hasn't been done this young, but the hope is that it could actually work, since it has been shown to work in teens and adults. So I just wanted to go over very briefly the program that we have here. Again, it's not specifically addressing suicidal behaviors or thoughts, but it is, if it's brought to the therapist's attention, absolutely something that therapists will, address. But it's our early childhood mental health program that looks at youth 0 to 6 years old, and they are primarily focusing on regulation of emotions. And what they do is they have parents, through parent-child interactive therapy, learn how to practice these skills. So you come in, you have a headset on as a parent or caregiver, and you are basically interacting with your child and getting coached via the headset from the therapist to kind of give you some practice, so to speak, on how to address emotion dysregulation in your child. So these skills that they are learning include reflecting the child's language back to him or her, describing the child's actions out loud to increase the child's awareness of the behaviors, and then also caregivers imitating good behaviors to demonstrate approval. So that's just the program that we do here for young children. And then some of the research that's been presented for therapeutic approaches, again, not much is out there, I will be very honest, but there was one study that was conducted that looked at enhancing home visitations. So it looked at youth 0 to 8 years old, and the project is known as Project Launch. And what they wanted to do was integrate early childhood mental health consultation into this already existing home visitation service that they had for Project Launch. And the goals were to promote parent and child behavioral health by enhancing home visitors' capacity to identify and address unmet mental health needs. So the families that were present in this study unfortunately had multiple stressors already that posed risk on the child. So those included single parenthood, lack of high school education of the parent, high unemployment rate, living with a family member that had a mental health concern already. So these are just some of the risk factors that were already present in these homes. And what they found is that home visitors themselves became more knowledgeable of the social, emotional, and behavioral health needs of the child. And they were also able to provide information for services for these families to address these needs. And these results were presented in 90% of the home visitors that this study looked at. So what that suggests is that maybe meeting families where they are, so for instance in their homes, might be one way to address some of the major risk factors that are associated with suicidal behavior in youth. And then another Project Launch that we found in the literature that's being conducted in Massachusetts looks at youth, again, 0 to 8 years old, and they try to incorporate what is known as the POWER team. So the POWER team is an early childhood mental health clinician and a family partner with lived experience, as well as being conducted in the pediatric primary care centers. So you've got the primary care physician involved as well. So the family partner with lived experience is a person who has raised a child with a history of social, emotional, behavioral problems. And they act as the liaison between the family and the clinician to make sure that the family's needs are being met. And the project incorporates identification of extreme stressors, parental mentalization, which is an intervention to support the caregiver's reflective functioning related to the child's subjective experiences of their emotions and their responses. And what the parental mentalization is thought to do is to help support the child's experience and regulations of their emotions, as well as help the caregiver's own regulation as well. And then also family-centered health promotion prevention activities for the whole family. So this project does family game nights, it does support groups, it does field trips for these families that are involved. And when evaluated by researchers, they found that the program improved social, emotional, behavioral development in children, as well as the caregivers, and that it also improved caregivers' stress as well as their depressive symptoms. So it actually decreased these symptoms that were being present in the caregivers. So implications. So what was found, it seems, is that establishing a warm relationship between the child and the caregiver is really important. Building the capacity of the caregivers to identify stressors, to educate the caregivers on tools and resources that are available for them to use when a child is having a breakdown in their behavior or having some difficulties with their emotions. Educating the children on their own emotions, feelings, and frustrations, building positive relationships within the family dynamics, so with all family members, not just the parent and the child or the caregiver and the child. And then also, if there is any trauma that has been experienced, addressing that trauma whether it be through child-parent psychotherapy, parent-child interaction therapy, trauma-focused CBT, is something that is definitely important to do. So overall, it sounds like the best approach is the team approach. Having the patient and the clinician work together to formulate a treatment plan like they did with the CAMS model, or having home visitors be educated and being used as a resource for mental health services for families, so that all parties involved can actually help families that have children who are suffering from mental health concerns. Also, all the programs address behavioral or emotional problems early on in development, which could be a preventative effect. So it could be a trickle-down effect that if we address these behaviors and concerns early on in children, that it can be a protective factor for when children become older and at risk for mental health concerns and suicidal behavior. And then finally, educating caregivers and making them a partner in the clinical care, and having them understand how to deal with their child's own emotional deficits and dysfunction, can actually give parents and caregivers a form of satisfaction, so that they don't feel like they're always in the back end and not able to help their child go through what they are going through. So my last slide here talks about resources. I always want to present those to folks so that they're aware. There is the National Suicide Prevention Hotline. Now that it's in Spanish, there's a crisis hotline as well, and then also the Trans Lifeline that's available both in the U.S. and Canada. And then I put the Prevention Center of New York State up there for you guys, as well as some other resources. And now, if we have some time for questions, I'd be glad to take some.
Yes, thank you so much, Dr. Sheftall, for this sobering and really informative and critically needed presentation. So yeah, we're now going to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit questions through the chat box. So we do have a couple of questions, so let's try to get through some of these. So this is more of a twofold question. Young children may not understand the finality of death, and I'm curious as to your opinion regarding working with youth that seem to express suicidal ideation, but do not understand that death is final, for example, that they won't come back. So my concern is the availability and quality of services or therapy that really are able to address this issue once identified.
Yeah, so that is an issue that was brought actually up during a workshop I was attending at the National Institutes of Mental Health. Do kids understand the finality of death? So I think, number one, that is something that's going to be on a case-by-case basis, unfortunately. Some kids do understand. They absolutely do understand. I've seen it in my own research that kids understand what I am asking when I am asking about suicide and suicidal thoughts. But some kids don't and think that, it's something that they will come back from if they do these specific behaviors. I think, number one, that needs to be addressed, saying that, this is a behavior that you don't come back from. And that's very important to do so that children don't have this sense of invincibility, so to speak, and that they are going to be coming back if they do something that could very much harm themselves. And it's true, the therapeutic approaches right now that address suicide and suicidal behavior in this age group haven't been, unfortunately, verified and validated at this age. So I think the CAMS model does have some promise, and we'll see how that goes with this young age group of kids that we're going to be implementing it with. But unfortunately, you're right. There aren't a lot of therapeutic approaches at this point in time. There are some out there for teens. So attachment family therapy has been shown to decrease suicidal behaviors and thoughts in children that are teenagers. And then, other dialectical behavioral therapy in teens and adults as well. But again, at this young age, we aren't there yet, unfortunately.
Great, thank you. Our other question is, how do you determine when it is attention-seeking behavior versus when it is an act of danger?
Yeah, so I always say take it as serious as you can. I'm that person, so I apologize to all those that may offend. I always take every disclosure as serious as I can because I feel like if I can prevent one life lost, then I'm going to do it. So I don't like to think that children do these things for attention, but that would be amiss if I didn't say that doesn't occur. I'm sure it does, but I do think ultimately saying that I want to die and saying that I'm going to kill myself should be taken as seriously as possible, no matter if it's the first time or the 50th time.
Absolutely. Thank you. So I know you mentioned during your talk that you were looking to adapt the form just to make it more appropriate for young children. So a couple of questions around that assessment. One, how young do you use, or I guess what's the age range for the SSS? And although I know you're going to be piloting it, do you know of any standardized measures or questionnaires that can be used with young children, so primarily the 5 and 11-year-olds or younger, that obviously does have age-appropriate language?
Yes. So to my knowledge, the SSF has only been used in teens, so I would say 13 and above, to be quite honest. And we are adapting it so that it is more child-friendly. For my studies that look at 6 to 11-year-olds, I use the SSRS, which is the Columbia Suicide Severity Rating Scale, and that has been used in children as young as 6 years old. And that assesses ideation as well as behavior. So that's the form that I'm using specifically.
Okay, great. Thank you. Sorry. Is there currently research available on trends relating to childhood suicidal ideation and attempts in terms of sexuality and or gender identity that you're aware of?
No. So for teenagers, absolutely. For young children as young as 5 to 11, no, not to my knowledge. There isn't any research out there. Unfortunately, transgender youth, LGBTQ youth are at a higher risk for suicidal ideation and do have higher rates of suicidal ideation and behaviors and deaths when you look at the data overall. But for young children, that isn't something that has been researched at this point in time. It is data that we are collecting, though. In my study, we ask a child about their gender identity as well as their sex, which is collected from their parent. Sex is collected from the parent. Gender identity is collected by the child's self-report. So we will have that information.
Great, thank you. Another question is, how common is it for a child who has suicidal ideations with plans to start making statements to cause physical harm to others versus hurting themselves?
Yeah, so that's a great question. And I will say that the one research study that we did find that children who died by suicide were more likely to have ADHD and ADD. They did not have conduct disorder. They didn't have ODD. And those are unfortunately some of the signs of ODD and conduct disorder are hurting other people, right? Depression in children is expressed very differently than depression in adults. Some kids will be more agitated. Some kids will be more irritated and will act out and hurt others. But that's not for every child. Some kids will be very standoffish and alone and not want to interact with others. So I definitely say if a child is acting out of character, that is also a red flag for me. If all of a sudden they're starting to have lots of fights in school, lots of fights with their siblings when they usually aren't that violent or not are very kind-hearted and don't have issues with those behaviors, that is also a red flag I would definitely want to address, with a clinician or a doctor or what have you.
Thank you. Our other question is there any data that has found a correlation between suicidal ideation or suicides and internalizing or externalizing symptoms?
Yes. And again, majority is going to be in adolescents and adults. So in terms of internalizing behavior, so suicidal ideation behavior is very much related to depression, depressive symptoms, dysthymia, anxiety disorders are also related to suicidal ideation and behavior. Schizophrenia, unfortunately, has also been associated with suicidal ideation and behavior, bipolar disorder, borderline. So, unfortunately, mental health concerns in general are associated with suicide and suicidal behavior. When you look at externalizing behaviors, the one finding that we had was the ADD, ADHD, which is considered an externalizing behavior, a cascade of externalizing behaviors, I should say. But the irritability that comes with depression or the agitation that comes with depression could be considered an externalizing behavior of sorts, depending on how that's expressed. But majority of what we know is associated with more of the internalizing aspect of symptomology versus externalizing.
Great. And I know you spoke to this a little bit, Dr. Sheftel, during your presentation, but I don't know if there's anything to add in terms of resources for suicide ideology assessments or screenings or protocols, primarily for that very young age of 5 to 10 or 5 to 11.
Yeah, so the one measure, I think we've only used it as young as 10. I will definitely put an asterisk there. The ASK, which is the ASQ, it's a 4-item screen that asks about suicidal thoughts and behavior. And that has been used in children 10 and above, 10 and above. The Columbia Suicide Severity Rating Scale has been used in children 6 and above, and adults as well. I'm trying to think of other screens that have been used. The PHQ-9, I want to say it's able to be used in children, I want to say 10 or 11 and above, but that primarily addresses depression. I believe there is one question about suicidal behavior on there. So that could also be something to consider. And then I'm trying to think of other screening measures. The suicidal ideation questionnaire, but that only goes down to 6th graders, I want to say. So again, older age group. I would say probably the youngest, the one that's been done with the younger children is the Columbia Suicide Severity Scale, and that is an interview format. Just so everyone is aware, that is not a self-answered questionnaire. You actually have to do that via interview.
Great. So, Dr. Sheftel, we do have a lot of questions, and for those that are still on the line, I do want to point out that Dr. Sheftel's contact information is certainly still on screen, but similarly, our information is also on the following screen. If you would like to have your questions submitted, we can certainly compile those, and at some time, Dr. Sheftel, if it's okay, you and I can touch base and have maybe a response to those questions. You can certainly send questions to ctech.info@nyu.edu. And certainly we do encourage you to visit our website for additional information on additional trainings. But I do want to be cognizant of time, so I do want to thank you, Dr. Sheftel, and thank you for everyone for attending. The slides and audio recording for this webinar will be up on our website within the next 2 to 3 business days. And once you leave today's webinar, you will receive a survey on the presentation. We would appreciate if you would complete that and provide your feedback. Again, for any questions, either based on the webinar or for Dr. Sheftel, please, again, feel free to address those to us and we can compile those and follow up. And then most finally, I do want to point out that we do continue to have events, so please be on the lookout for your email. But on behalf of CTAC and our presenter, thank you for joining us today and have a great rest of the day.
Thank you.